Hi, my name is Eric Wong, and today I'm going to talk about the pharmacogenetics of Abacavir hypersensitivity. Abacavir is one of the most effective antiretroviral drugs in use. It's a deoxyguanosine-based analog, which is metabolized into abacavir transphosphate and acts as a nucleotide analog reverse transcriptase inhibitor. It has high oral bioavailability and usually used in combination with another retroviral drugs. With a half-life of 1.5 hours, it's metabolized in liver by alcohol dehydrogenase and uridine diphosphate granultransferase. Although it has high viral suppression rate, it is not without problem. 2 to 6% of patients receiving these drugs develop hypersensitivity reactions, usually within the first 6 weeks of initiation of treatment. And the only clinical test available was skin tests, where a small amount of abacavir was put on skin and reaction observed. This is time-consuming and occasionally causes severe reactions, and skin biopsy have shown that these reactions are immune-mediated. This picture shows how this hypersensitivity reaction looks like clinically. In severe form, it can cause skin necrosis mimicking severe burns, anaphylactic shock, multi-organ failure, and even death. So what causes these reactions, and is there a better way to identify patients at risk? Many clinical studies does give us some clues. First, a meta-analysis by Smell et al. In 2002 showed ethnic African has a much lower hypersensitivity rate as compared to European descents. Another study had demonstrated strong familial linkages, and this predisposing factors is inheritable. Subsequently, histopathology study confirms the reaction is indeed immune-mediated and possibly associated with human HCH genes. So with this evidence, in 2002, 2 papers in Lancet described, which identified a strong association of HLA-B 5701 to hypersensitivity in patients on abacavir. All these genes have a p-value of less than 0.0001, which is highly significant. These findings were subsequently verified by 2 major studies. The first one, SHAPE, a retrospective study, found that the presence of HLA-B 5701 alleles has 100% sensitivity to positive abacavir hypersensitivity reactions. And in 2008, a large randomized controlled trial confirmed this finding with 156 patients involved. It concludes that HLA-B 5701 have a 100% sensitivity and a 96.9 specificity for hypersensitivity reactions. This is a major breakthrough, and the gene associated with this reaction was identified. So what's HLA-B 5701? It's the gene that encodes for a class 1 human lymphocyte antigen molecules, which is involved in triggering immune response when subjected to foreign antigens. HLA genes are highly polymorphic and variable, with a heterozygosity score of over 0.9 across all major ethnic groups in America. Abacavir are involved in the hypersensitivity reactions via 2 possible mechanisms. It can either interact with the endogenous peptide to activate the HLA complex, or bind directly to HLA-B 5701 molecules. Either way, the end product is the activation of CD8 plus T cells and a forced immune response with various immune mediators, including tumor necrosis factors and interferons involved. One interesting point to note then is that unlike many genes we have discussed in the past 2 months, HLA-B 5701 is involved neither in the pharmacokinetics nor the pharmacodynamic pathway of abacavir. This illustrates the mechanism in which the metabolic of abacavir upon entering cells causes activation of HLA-B 5701 by binding at the immune activation site and causing CD8 cells activations. If we take a closer look, we can see that abacavir binds specifically to the peptide binding groove of HLA-B 5701, which alters the protein configuration and the spectrum of peptides that binds to the molecule. These alterations causes forced activations of the HLA complex in the absence of foreign antigens. A closer look at the 3D models of abacavir binding to HLA-B 5701 complex. The green and yellow represent the HLA protein structure, whereas the gray molecules is the abacavir. So what does it mean to the patients? Abacavir is prescribed to over 1 million patients in US per year, which translates to almost 80,000 patients potentially affected by the hypersensitivity reactions. And with this strong evidence, FDA have issued drug label warning recommending HLA-B 5701 screening before administering abacavir or any combination drugs. And the Clinical Pharmacogenetic Implementation Consortium have published guidelines on HLA-B genotype and abacavir in 2012. In pharmacoeconomic terms, screening for HLA-B 5701 before initiation of treatment saves over $300 for each patient being treated. And therefore, HLA-B 5701 is currently widely adopted in healthcare institutes across the United States. Of course, the story doesn't end here. There are still a lot of questions remaining unanswered. Is HLA-B 5701 the only gene responsible for abacavir hypersensitivity? Studies have shown us that only 50% of patients with HLA-B 5701 develop hypersensitivities. So what accounts for the remaining 50%? We don't know yet, and this is just one of the many questions we may be able to answer with new tools like gene sets enrichment analysis or connectivity maps. If you have any questions or comments regarding this presentation, please feel free to contact me at this email address. The slides used in this presentation and the bibliography is available at the link below. You can also scan the QR code to get the slide. Have a nice weekend.